foundation of all aspects of services that we give to our patients needs to be based on evidence, following evidence-based practices. However, unfortunately, when it comes to wound care, probably we don't follow this all the time. Maybe we are using dressings that we have been using for many years and we think we know that they do work. Or else we just follow what we have been doing with our colleagues for our patients. But unfortunately, that is not the basis of what we should be doing. If we go back a few years and look at the event that started all the movement about evidence-based practice, we have to mention Dr. David Sackett and his colleagues that started this movement for medical and health professionals to make sure that what we are providing for our patients is based on robust evidence. They came up with a very good definition of what evidence-based practice is when they suggested that it is the conscientious, explicit, judicious use of current best practice in making decisions for our patients. What does this include? This doesn't include just looking at empirical evidence. We have our own experiences, we have our own judgments. Our patients has got their own preferences, so amalgamating all these three together is really, really important. If we're looking at the best evidence out there, it has to make sense that what we are looking at does link with what we are providing care for our patients, does link with our patient populations, their preferences, religion, etc. One of the things that we also talk about is reflective practice, that although it is not a major part playing in evidence-based practice, however, in our daily practice, it should play a very important part. So what is reflective practice is basically our ability to reflect on our action, take a critical stance and look at what we are doing, how it is affecting our patients. The process of thinking about this, and it is not just thinking about what we have done, but also reflecting on our future actions, reflecting as a group totally, to make sure that what we are providing for our patients is the best care and will give the best outcomes. So how do we set about implementation of evidence-based practice? The first thing is getting that sense of inquiry. Understanding that we need to challenge the status quo. Understanding that there are things out there which might be better than we are doing today. So in order to start with the inquiry, we can use the PICO methodology. So the PICO is an acronym which stands for Patient Population, Intervention, Comparisons, and Outcome. This is usually type of hypothesis the authors start when they are formulating a hypothesis for a clinical trial, for example. But PICO can be used in everyday life and definitely can be used in our daily practice. So let's try to take it in context. We are running a clinic with patients who come to us with diabetic foot ulcers. So our patients are diabetic patients. The population is diabetic patients with foot ulcers, which leads us to the problem of, for example, not healing in a timely manner. The intervention that we have is what our current practice is, understanding what we are doing, but then comparing it to a new treatment. We implement the new care, compare the results, and that will give us the last part, which is the outcome. So making it in a methodological manner will give us the results that are not necessarily better, but at least we have challenged our status quo and understood if there are methods out there to manage our patients which can give us good results. Because at the end of the day, the inquiry starts because we have looked at what the evidence is telling us, and the evidence is suggesting maybe that we change our practices to new dressings or to new standards of care. The second part of evidence-based practice of the implementation process is once we realize that we need to change practice to understand what that new intervention is, we need to acquire the evidence. acquiring the evidence is understanding also what type of evidences we are looking at. We have been looking at the hierarchy of evidence for many, many years now. And we have at the top of the pyramid the meta-analysis, the systematic reviews, and the randomized controlled trials, which is all well and good because these are very, very robust type of evidences. However, nowadays this is being quite challenged, and people are talking about the naturalistic way of interpreting studies. What does that mean? And what does that mean for us? So we have a systematic review, we have a big randomized control trial which showed us amazing results. However, how do we know if what happened, for example, in Germany will work in Australia or India or wherever? This is why then we need to do observational studies, we need to do case series to understand the application of that evidence in real life. So yes, those systematic reviews, those meta-analysis, those randomized control trials are very important. However, making sure that they work in our country, making sure that they work with our patients by means of doing real-life data analysis is really important. So we can't say that one is bigger than the other. We can say that one is complementary to the other, and this will give us the good picture of what would be the best new intervention for our patients. But if we look at evidence, is it that important? Does it change the way we talk? Does it change the way we do things? When it comes to wound care, the best example that we can give is a study that was published in the early 60s, 50 years ago, where a British scientist did a small study on some animals. He did some wounds on these animals, some of them he left exposed, some of them he covered, and what they found out in preclinical and clinical trials was that getting a moisture balance in the wound enhances healing. They didn't really understand why at the time. We know a lot better now. But at the end of the day, a simple publication on a few animals, few pages, changed the way we think. This created a whole revolution where we saw in the 80s the creations of many new dressings, and we changed the way we think, where we always thought that a dressing is just there to cover the wound. Now our new ideology is that dressings are there to create a wound healing environment. But if we are looking at an article, how do we know if it is of good value or not? Because let's be frank, it doesn't mean that it is published, that it is totally accurate, and we should follow it blindly. This is where our inquisitive mind becomes a challenging mind. We look at what has been published with a critical eye to make sure that the evidence that is being projected in front of us is of good value. In order to do that, we need to critique it. It doesn't need to be a very complicated situation to critique. I can give you an example of what I personally prefer to use. I use the Critical Appraisal Skills program that you can go on their website and download the questionnaires for each type of study that you can find. It's about 14 questions per article. But by doing so, we are making sure that that article, that paper, that clinical trial that we are reading is of good value and should be considered for changing our practices. So at the end of the day, when we are looking at these type of articles, what do we need to look at? We need to look at if the publications that we are looking at has proven three very important things. The first one of that is being clinical efficacy. Saying it very lightly, does the dressing do what it says on the box? If we have an antimicrobial dressing, does it actually reduce the colonies of microorganisms? Does it give us a safety level that although it's a good antimicrobial, it is not cytotoxic to the healing process, for example, cytotoxic to fibroblasts? So the first thing that we are looking at are the results. What have the results that been suggested in that article? How do they relate to our daily practice? And will they show that that dressing we are going to use will give us the results that we ultimately want to use? The second thing that we need to look at is the health-related quality of life of our patients. Unfortunately, many times we look at the efficacy, the wound healing, wound area reduction, reduction of exudate, etc. Do we give that much importance of how a dressing is affecting the life of our patients? And when we think about health-related quality of life, usually we think about pain, about odor, about exudate. But remember, the most important part for our patients and their health-related quality of life is shortening healing time. Shorter healing time means less distress, less cost, etc. Which brings us to actually understanding the third part, which is, does the new treatment give us a good cost benefit? Is the new treatment that we're going to implement save us money? And usually that confuses us, because usually new dressings will be more expensive. So how do we go around with that? So some evidences actually suggest that the cost of a dressing makes up only about maximum 20% of the total cost, because the total cost of care is how much money was spent from the day you met the patient till the day that you healed totally that wound. And that includes a lot of things. Even if you're doing just the dressing, it is not just the cost of the dressing, it is your time. It is the price of the dressing pack and the solutions that you are opening, the apron, the sterile gloves, etc. But also the indirect costs. How much is it costing the patient to come to the clinic? How much is it costing for the patient to be probably out of work because of that wound? So when we are doing our cost analysis, we have to look at all these costs. And thankfully enough, nowadays, once they do some randomized control trials, they do a post-hoc analysis of the health-related quality of life of the patient, as well as the cost-benefit analysis. So if you find an RCT that talks about a new treatment, see if that RCT has got post-hoc analysis, which you can relate to the clinical efficacy, which was the first results that came out, the wound area reduction, etc. The second one is, how did it affect the patients? Did it reduce stress? Did it reduce anxiety, etc.? Third, and importantly, is, did it reduce costs? So giving an example of a dressing that has been introduced in the past few years that manages diabetic foot ulcers, a study was done, a double-blind study actually was done, to show that in neuroischemic diabetic foot ulcers, the healing time is reduced drastically. Then they did the post-hoc analysis for the health-related quality of life, which showed that it affects the patient's life very well. Thirdly, they did another post-hoc analysis where they did a cost-benefit. And this was done in 7 countries, showing how much we can save. Giving an example from the UK, they suggested that if this dressing is used in 25% of diabetic patients, the NHS from the UK could save up to £5.4 million per year. So once we find one article, sometimes it makes us look at all these post-hoc analysis to make sure that we have a homogeneous result that includes all the 3 domains. The next step is probably one of the hardest parts. So we have found the evidence, we have analyzed the evidence, we know it is great, we know it is amazing, but the challenging of the status quo is sometimes very difficult. We have to consider a plan of how we are going to convince our management, our colleagues, how to change our practice. Because status quo is quite comfortable and change is a bit unsettling. So one of the things that we are not going to talk about today, but I do suggest that you go and look for, is theories of change. Change management is a very broad subject, which is really, really interesting, and understanding how it can help you in the application of best practice. One of the biggest examples I can give you, and one of the easiest probably examples, is identify change agents. See whom in your facility is open to change and help you to implement that change. What is also important is that while you are affecting the change, from the very first step, creating the hypothesis, till the application and thereafter, Make sure that you note what is happening. Keep a good record of all these steps, the pros, the cons, what you find easy, what you find difficult, and at the end of the day, also after implementation, what were the results? Publish these results. One, it will give you credit for all the hard work you've done, but more importantly, it helps other clinicians understand that they can change as well. They can take your plan, they can take your example, implement it in their facilities. And this is the spread of evidence-based practice, because it can be quite infectious. Once one facility starts with evidence-based practice, usually you see clusters following suit. How are we going to do the transformation? One of the ways how to do it is called the ACE STAR model of knowledge transference. The first part is the discovery of research, as we said. We are quite lucky because once we look at a problem, we usually find that there were already systematic reviews done, and probably we will also find best practice guidelines as well. Let's take again the example of the diabetic foot. If we look at the IWGDF, which is a group of experts dealing with the diabetic foot, they do a systematic review every 4 years, and based on the results of those systematic review results, what they do is they propose to us best practice guidelines. Again, if you are looking at best practice guidelines, also look with a critical eye, making sure that these guidelines are robust, making sure that these guidelines are there with the sole intention of making our evidence-based practice better. What we need to do also is look at the summaries. The systematic reviews will give us that, the guidelines will give us that. So when we are looking at summarizing and putting the guidelines, that's already been done. What I do suggest is that don't leave guidelines as international best practice guidelines, but adapt them to become your policy and your own guidelines in your own facility, clinic, hospital, wherever you are. Because then it means that everybody has to follow them. It is not just an international publication that we can follow or not, but if we transfer that to a policy, then basically everybody will follow it. The integration into practice, making us more knowledgeable about change management and understanding how to implement change in our facility. The job is not done until you evaluate. So once you have put something in practice, you have to go back and analyze at certain points if the objectives that you have set are actually being reached. If not, why didn't we reach our objectives? Maybe we missed a place, maybe we missed something. So that evaluation part is a very important process in your integration into practice. What are we talking about here is history in the making, basically. People who, like me, have been in healthcare profession for a long time, we've seen practices changing so many times. What we talked about previously, that study in 1963 by George D. Winter, changed totally the way we think. And it didn't just change us, it also changed the industry, who realized that they need to start creating dressings that are interactive with the wound bed. Another type of revolution that was done not just in wound care but in all medical and health is the new ideology of multidisciplinary teams and interdisciplinary teams. We have moved away from having the general at the top dictating to the troops at the bottom. We have stopped with one group not looking and talking to another. If we talk, for example, again with the same example of the diabetic foot, we need to have the vascular surgeon, we need to have the wound care nurse, we need to have the podiatrist, nutritionist, psychological support. Everybody has got their own expertise, and that is why it's very important. And this came about through studies, through evidence that people implemented. Another big revolution that happened was in venous leg ulcers, compression therapy. We now know the importance of multi-component, multi-layer bandages. We moved away from the old hierarchy of 4-layer bandaging that the patients hated and didn't comply at all with. And now we're moving to, for example, 2 layers, or nowadays even 1 layer. But again, what type of multi-compression bandages should we use? And if we look at the evidence, we look at systematic reviews, we see that there are some systems which are a lot better than the others. We talked about the dressing that has changed the wound management in diabetic foot ulcer, a dressing which is made from sucrose octasulfate. This brought quite a bit of a stir in the international community because it was the first time ever the IWGDF included a specific dressing in their guidelines. And it started a ripple effect because it wasn't only the IWGDF. Then the NIC from the UK looked at it. Then Diabetic Fit Australia looked at it and implemented it. We have VAID from Vietnam who have implemented it recently in Germany. So the ripple effect of evidence, that beneficial effect of evidence, at the end of the day, creates a revolution in our head, gives us that inquisitive mind to challenge our status quo and say, you know what, maybe what we are doing for our patients is not of the best quality that we can give. Very importantly, we need to understand that we don't know what we don't know. We get to know things by looking at evidence, because it is even more dangerous when we think we know what we don't know. The danger is that we are thinking that we are implementing the best practice for our patients, but at the end of the day we are not. And referring to one publication that came out a few years ago from studies from the Netherlands and the US, where the results were quite shocking actually, where they suggested that about 30 to 40% of patients were not receiving care according to the research evidence. They actually found out even more worryingly that 20 to 25% of these patients were receiving care which was either futile, not needed, or else could be even harmful. And this makes us reflect on our practice in wound care. Why are we still using, for example, dressings which are greasy? Where we mention again Dr. George Winter, who published a paper in 1975, who suggested that these dressings are not beneficial. We are still using different types of cleansers, which we know are cytotoxic to some cells. And this is one of the phenomena of tissue viability and wound care, because in other specialties, if we have a single small doubt that a treatment can be other than beneficial, it is not approved, it is not used. Take chances in wound care. This is what evidence-based practice, and this is why we chose this as the first module in this program. Create your inquisitive mind, challenge yourself and your colleagues, challenge the status quo, look at what the evidence is suggesting, because at the end of the day, what we are doing here is bridging the practice evidence gap. This gap that we have been talking for years and years and years and years, which is still there. And there's still a lot of debate. So maybe we know that this cleansing solution might be cytotoxic to fibroblasts, but you know what? We've been using it for the past 100 years. That is not what evidence is. Evidence-based practice is scientific results which have been tested over and over and over, which for you as clinicians, it will give you the peace of mind that you know that what you are doing for the patients is the best possible solution. The patients don't know if we are giving them the best care, but what they do know is that their wound is healing faster, the odor is gone, the exudate is reducing, and they don't feel pain anymore. On the other hand, when it comes for the health economy, for the budgets of our hospital, at the end of the day, for the budgets of healthcare in all our country, is that we are saving costs and getting better results. So at the end of the day, implementation of best practice based on best evidence will be beneficial for you as a clinician, will definitely be beneficial for your patients, and fortunately enough, the third step would be that it is beneficial for the pockets of our accountants in our hospitals who have to approve the dressings that we want to buy.